Good morning. First of all, thanks for joining me today. I'm always impressed by the diverse topics that are on the Rail Wellbeing Live. First of all, just like to thank you all for joining me today. I was asked to present today and look at a different topic. So I wanted to do something a little bit different to what's been proposed previously. As I'm not an accountant, I can't advise you on tax, but what I can do today is I can advise you on where you best to invest your time and efforts over the coming years as we go into an ageing time frame. I'm Geoff. I'm an osteopath. I'm registered for the last 14 years. I'm also an MSK ultrasonographer and a manual handling trainer. And I've also got an interest in ergonomics and human factors. In terms of a rail context, I've worked within the rail for the last 8 years, providing on-site MSK clinics or musculoskeletal clinics in a variety of locations, from depots, trackside, even through to control rooms. And what we do is we do the assessments, treatments, rehabilitation and the monitoring of various diseases and conditions to keep the workforce moving. The populations will range from graduates to retirees and in a wide range of roles. Prior to rail, I worked in a private clinic, but also worked with professional athletes in judo, weightlifting and cycling. Today, what I wanted to sort of pitch more about is a useful way to be thinking about the industrial athlete. And the useful way to be thinking about this is the idea is that it's not just an elite sport. It's about how our bodies work. In sport, we accept that readiness changes. We accept that performance varies and recoveries matter. In the railway, work isn't that different. Repeated physical demand, variable conditions, and there's fatigue in the background waning away. In an aging workforce, the job typically stays demanding. Standards don't change, but recovery takes longer. Strength also arrives a lot slower, and tolerance narrows. That doesn't mean that we're incapable of working or unfit. It just means that there's less reserve. So what that means is how we link those is more about physical readiness, strength, recovery, coordination, and low tolerance. Parts that are often missed within the industry are that people are still coping, still turning up, and still doing the job. The bits that become visible, and when they become visible, is when pain doesn't settle, fatigue builds, and at best, absence appears, but at worst, we have a safety incident. So a manager that might feel that things feel sudden or out of place, but typically these things have been drifting in the background for months, possibly years. So today is not about fitness or work. It's not blaming age and saying that we're incapable as we get older. What I've learned over my time is never judge a book by its cover. I've seen athletic patients at 60, and I've seen metabolic arthritis in your early 40s. So what we'll cover today mainly is about how readiness changes, why recovery becomes unreliable, and what managers can act on earlier with the right mindset and the right questions. Speaking about questions, if you do have any questions, please leave them in the chat and we'll answer those at the end. Can I just make sure that we keep those sort of general themes and organisational rather than personal, just so everyone can relate to it. Before we go any further, just want to interpret how to interpret this session. What you'll see here in front of you is a bell curve. So the people that we talk about typically sit in the middle of that, and that's the 80% of the population. It's not an individual prediction. These are variances across that time frame. So top performers will be on 110%, and people with other comorbidities will be on the other 10%. But what we do find is that majority of people will sit in at 80%. So we're talking about the middle majority, those people who are still operational, but the readiness is drifting quietly in the background. The important point to make here is that we know that age, absence doesn't increase with age, but we do know that age increases musculoskeletal risk and prevalence of work-related disorders. That said, many people maintain capability well into later working life. Important point number 2 is readiness is modifiable. It can improve, it can decline, and it can fluctuate day by day. And what influences readiness is typically workload, recovery, health, and early recognition, which is what we're going to go through today. Typically, earlier interventions tend to be smaller, less disruption, with better outcomes. Later, as we find these conditions, pain won't typically settle, repeated absence, and unfortunately, some safety incidences. So we're going to be looking at patterns, not people, reacting earlier and not reacting later. So just to set some terms here today, so you'll see 4 terms up here in front of you. 4 terms I'll be referring to today. The top 3 are typically conditions that all, either as a collective or by themselves, will affect the RFD, which is at the bottom, which we'll go through in a little bit more detail in a second. So typically we have what's called sarcopenia. So this is typically the loss of muscle quality and a loss of reserve, mass, strength, and function. What it's not frailty, although it does contribute to frailty long term. That doesn't mean that you're not incapable, and it doesn't mean that you can't do the job. Why does this matter? Typically in a working environment. So typically day to day we'll still feel fine. It just means that we've got less buffer, less reserve when things change. So when does it show up typically? Typically on like long shifts, pain flare-ups, or poor recovery after a long shift, etc. The next one that we'll look at is osteoarthritis, often called wear and tear. Better to think of this as more as a loss of shock absorption. And why this really helps is it explains the sensitivity within the joints, and pain with some workload and low tolerance is reduced. We know that MSK conditions rise with age, particularly 45 plus and especially 55 plus. However, metabolic syndrome can start in your teens, which can obviously change your pattern from earlier ages. So it affects all of us. Aging is unfortunately a process as soon as we're born. We then have metabolic syndrome. So again, we're not diagnosing here. It's not a single disease. What it means is a cluster of factors. So blood sugar regulation, cholesterol balance, blood pressure, and central adipose. And why it matters is it's chronic low-grade inflammation, which affects repair, affects recovery going forward. So key distinction with this is it doesn't usually cause sudden injury. Some of the factors within there we don't even know that we've got until we get blood tests, until we get our weight and height and blood pressure taken. But what we know is that our tolerances to different activities will change over time with those. And then we come down to the last but not least, which is really important, probably the frame of today, is the rate of force development. So this isn't your max strength. This is typically how quickly force is available. So think of it as like a light switch or a dimmer switch when we might be strong, but it's how quick we can pull that power in. Okay. Why does this matter? Well, it matters greatly, especially on the railway, especially on ballast, when we're looking at sort of slips, trips, and falls. And we need a strong and a quick recovery from perturbation. So the rate of force declines earlier than strength. It declines with sarcopenia, as well as we'll see later, and it's affected by OA or osteoarthritis and pain, and it declines with muscle quality. So bringing it together, why this matters: we could have the same person, same age, same job, but the differences in the variances in their background or their readiness will have very different outcomes. So these 4 ideas explain variability, they explain drift, and they explain why early support matters. So this slide here, what we're looking at, this explains the problems, why sometimes it might feel a little all of a sudden, when in actual fact, things have been changing in the background for a long time. As we can see with the pink line here, this is task demand. So that's, again, what the job requires, which is largely unchanged over time. Then we have the amber line, which is your capacity unmanaged, which is no early visibility and no targeted support. And then we have the blue line, which is capacity where it's managed. So that's where it's training. We're looking at recovery focus and early intervention. So the job stays the same, capacity changes, and what's really important is that gap between those. So a really good way to think about this is probably a muscle pension, a useful, if we can invest in it earlier in life, we can live off the investment. If we come to it later on in life, it just means that we have to be a little bit more focused with our strategy and where we're actually going to put that time and effort in. So with the unmanaged drift and the amber, without investment, we can see that the capacity drifts down. It's gradual, it's quietly, and it's unnoticed. Some life stages will accelerate this, and some of the talks that we've seen today, like menopause, can be affected, but also things like an injury or surgery, hence why rehabilitation are important, and pain education. So what this looks like is it's not sudden incapacity. People are still working, still active, but just recovery is less predictable. Pain flares more easily, and it looks more like inconsistency. So not at work if it's a sedentary job or in everyday life. So the type of things that we might see as we get older is getting out of bed seems a little bit harder, or poor sleep hits us harder the following day. Kneeling is less comfortable, and more importantly, it's the more noises when we're moving. So again, we might have, for a typical example, here, we might have two people the same age climbing up a set of stairs. So the unmanaged typically might get up, there'll be a slower push off, they need momentum, and there'll be a higher effort required. The blue line, with people with blue and who train, could be the same task, better leg drive, more control, and faster recovery. So both can do the task, but it's just difference is the cost of it. So what manage really means, manage doesn't mean it's easy or less demanding. It means investing intentionally, strength training, nutrition, hydration, sleep, and stress management. So if you start earlier, small inputs go a long way. If you start later, the investments need to be more focused and more deliberate. So the goal is not stopping aging, we can't do that. It's to protect the quality of life going forward, and more importantly, avoid surprises. So remember that muscle pension compounds, and also neglect also compounds. So what we've talked about is the drift. We talked about how tissues changed, and this slide here shows how that those changes accumulate. So it's not a single event. This isn't one injury. It's not one failure. It's a lot of small changes over time that all add up, like compound interest, which is positive or negative. So as we can see with the muscle line, we can see that muscle quality gradually changes, not just in size, but more fat within the muscle, less efficient activation. We've got the same effort, but less output, and fatigue arrives earlier. In tendons over time, tendons adapt too. The elasticity changes within our tendons, so the spring behavior alters. The energy storage is less efficient, and repeated tasks will cost more. So again, it's all about recovery. When we look at joints, so joints rely on cartilage and muscle support, and when the muscle quality drops, the load shifts to the joint. Yet metabolic response delays recovery, so it's a little bit different. A less tolerance to repetition, it's not damage, the margin's a lot less. So when we combine the effects on muscle, tendon, and joint, the system still works, but it's just a little bit less forgiving. But what the most important factor, and the things that we mentioned previously, is the speed. So the speed of the force generation that we're looking at, so it starts to slow down. And we measure this as what's called the rate of force development, as I mentioned earlier. So again, you can have strength may still be there, but it just arrives a little bit later. And that matters again back to slips, trips and falls and balance corrections. So these changes don't stop people working, like I said, they just shrink the reserve, and that reserve shrinks, and then the system becomes less forgiving, and small issues compound faster. So this explains how tissues change. The next layer explains why some people change faster. So, 2 seconds. So this here is an ultrasound scan. So this is a cross section of the thigh. So those of you who don't do ultrasound scans, which I can't imagine many people do here, so I'll just explain a little bit about the technology. So what we have is we use this little device here, which is a handheld ultrasound scanner. And the way that I like to see this is that we have like a little row of tennis balls all falling out. And when they hit a hard surface on the screen, they will show white. If they hit a soft surface or something that's less dense, they will show black. So what we have black and white and a range of grayscales in between. So that gives me an idea of what the tissue is looking like. So if we look here, what we can see is, so what we've got here is we've got two images here of ultrasound. The one on the left, so if we just highlight there the yellow circle, that looks at what's called the rectus femoris, which is a muscle in the thigh. And you can see on the grade 0 that the muscle itself has less white. So, and the white for us shows up as fat. And if you look over on grade 3, we can see the size of the muscle changes. We can see the depth of it that changes. And we can see that above it, we can see a bigger or a greater layer of fat. So if we look at the bottom there, you can see a little semicircle. That's the bone. There's a muscle on top of that. And again, if you look on the grade 3, that's a lot lower, but the fat is a lot thicker and the muscle is fatter in itself. And why does that matter? Well, typically when you muscle composition and the tissue quality of that, so one has more contractile muscle, one has more fat occupying space. So both muscles will still work. It just means that people, the efficiency of that muscle will be different. So, but one produces more efficiently. Fatigue will set in sooner than the other, and recovery will be slower, especially in the grade 3. So, in our clinics, in the MSK clinics, we sometimes see these tissue patterns. We can see the increased fat within the muscle and the changes within the tendon. These often correlate with metabolic factors, but this doesn't give us a diagnosis by itself, but it does explain why recovery will be a little bit different. So adiposity within a muscle, one important point to clarify that it's not just all about load for the muscle. So adipose tissue in itself isn't passive, it's biologically active, and it releases inflammatory signals within the body that increase pain sensitivity to load, temperature, and chemical. So this means that joints can feel more painful, muscles will fatigue sooner, and recovery will feel a little bit harder. So this might be when someone sort of says, I've been doing the same things, but suddenly everything hurts. Why does that change? Well, again, this is a gradual process. It's something that's been ticking away in the background. So this slide here that we're talking about is about metabolic syndrome and osteoarthritis. So this slide brings together what we've been building up from the muscle to the joint and how metabolic syndrome influences osteoarthritis, not as separate problems, but as a system. So the joint in context, so the joint is in the middle. So on the left-hand side, we'll see obesity. So as I've just mentioned previously, obesity can affect how we process pain. It produces inflammatory signals that circulate through the body. And those signals increase pain sensitivity and reduce tolerance to repeated load. In many cases, it's increased pain changes behavior. And that's not because people are lazy, it's because people are trying to protect themselves. So we class this as doing the wrong thing for the right reason. So, and because pain creates fear, we then have fear leads to activity avoidance. And then obviously then what happens, we get reduced movement, accelerates the tissue deconditioning, and it's just a negative compound effect. So again, that's the important reason for exercise, but also prehabilitation and rehabilitation when we do such things. Many people understandably believe that the body weight itself is the main problem, and it's true partly, but it's about reducing weight. It's not about reducing mechanical load through the joint. When we even look at non-load bearing joints such as the wrist, they're also affected by OA, and there is a strong correlation with metabolic syndrome. So it doesn't have to be a weight bearing joint. So the correlation necessarily doesn't fit when we talk about load bearing versus osteoarthritis. So we know that metabolic syndrome, adiposity, certainly matters. So when we look at glucose regulation, again, poor glucose regulation, type 1, type 2 diabetes, we know that it affects the tissue repair. We know that it changes the collagen fibers. And with that, then obviously we know that people with diabetes are more susceptible to frozen shoulder, carpal tunnel, trigger finger, and other conditions. So it doesn't usually just cause a sudden injury, it just reduces resilience over time. And we look over at lipids. So again, this is abnormal lipid profiles or high cholesterol. So those are also linked with changes in the cartilage, the bone, the muscle quality. One of the more sort of recent cases we've seen is those with familial hypercholesteremia, especially it's an inherited disease, are more susceptible to cholesterol deposits, especially within the Achilles. So this is really important for those who are out on the track, and getting Achilles pain is also to make sure that you get your cholesterol checked, especially if your parents have high cholesterol. The other thing that we look at is hypertension or high blood pressure, and again, this is about reduced microcirculation within the joint. So it affects the nutrient delivery and the waste removal from the joint. So again, we have slower recovery and reduced tolerance. So metabolic OA, as we all refer this to, it's metabolic osteoarthritis. Again, it's mechanical load, which it still matters, but the biological response to load changes. So what managers will see again is typically we'll see the same person doing the same job with the same exposure. The pain becomes more persistent, recovery is less predictable, and flare-ups from certain tasks that used to be tolerated. From the outside, this can look inconsistent or it can be out of proportion, and it matters because the job suddenly didn't change. It didn't become unsafe. The system, the margin narrowed. So this explains why OA can feel unpredictable in an aging workforce. And again, that's why we use blood tests to assess certain blood markers, which will sort of base around those, especially for metabolic syndrome. So the take home here is that remember all of these factors are modifiable. Earlier visibility allows earlier interventions. So pain compounds fastest when the changes behaviour. It's not just the biology. So let's see if you've been listening or if you've gone off for lunch break. So as you can see here, again, we've got two images here of an ultrasound scan. Again, these are cross sections of the thigh. So just in the chat here, just put in which ones that you think, which muscle that you would like. So again, just remember that we've got, we're looking for dark tissue, which has got muscle tissue. So think of these as steaks. Which steak would you like if you was to eat one today? Okay, so what I can see is here is the B is, I'm going to say, the correct answer because we've got more black within the tissue. So when we look at sarcopenia, for instance, it's important because what we have is sarcopenia comes in and it just, again, it doesn't just fade in. We see that it does change gradually over time. And it's a gradual shift in composition. So it's quite similar, or there is an overlap with sarcopenia and metabolic syndrome and osteoarthritis. So again, we can see the changes within the tissue, and again, especially there within the muscle tissue. And it matters. And it matters because people can still do their job. They just don't bounce back as quick. So sarcopenia often overlaps with the metabolic syndrome, which is really important to understand that. Next here, so again, this is what we called rate of force development. It's not reduced rapid force development, so I do apologise there. So this sort of brings everything together, what we've been talking about. This is where it lands, and especially in sort of frailty, sarcopenia, and all these other factors that we've just spoken about today. So what you're looking at here is on the graph, we've got the vertical axis, which shows force, and we've got the horizontal axis, which shows time. And we've got two curves within there with the same task, but we've got a different response. So again, think of this as on the green one here, we can see that the force is a fast light switch, it's turned on very quickly, and that same capacity is available straight away. If you look over on the force on the amber line, we can see that we've still got the same output, but it just takes slower. And that's really important when which is an important distinction, is because when we're looking at slips, trips and falls, you can see that they happen within a very small time frame. And so when we have all of the conditions that we spoke about today, they can affect muscle and affect the output. And that's really important going forward. So it's a critical window that we're looking at there for the slips, trips and fall recovery window. So timing matters. It's not the output, the timing matters, and how quick we can pull on that muscle tissue. One of the ways that we look to assess that, we can do that if you look onto you can see a gentleman there pushing on the quadriceps. And what that does is using a dynamometer, and what that does is it shows the total force and the rate of force that is applied. So we can measure certain characters that we would see in preventative slips, trips and falls, and those who are potentially at risk. Okay, and so when we do that, we look at an objective force is how quickly it's generated. We can look at symmetry, we can look at variability, and how that person feels giving that much power. Given that speed. So is there any pain? Is there any confidence changes with it? Is there a fatigue, or is there change in effort from them in terms of rate of force development? So force alone is not predicting real world performance, especially in unpredictable environments. So this is particularly useful for manual handling guidance and helping tailor advice to readiness, not just to the role. So it is not a pass or fail or a capability assessment. It's just highlighting risk to the workforce and providing advice, exercise plans to support them. So it's understanding readiness in a fun way, but also objectively. So that's the mechanism. So the next slide is sort of introduce the industrial athlete. And well, like I said, when we think in sports terms, athletes aren't judged necessarily just on effort alone. They're judged on readiness, how well the body tolerates load, how quickly it recovers, and how it performs when conditions change. So although we have different environments from the athlete, they're very similar to those people in the industry. So it is similar. Well, railway workplaces, repeated physical demands on the body, it's unpredictable conditions, fatigue in the background, time pressure, and those demands are closer to sport than we often acknowledge, I believe. So how we've traditionally framed work is, historically, we haven't framed work in this way. We look at physical capability, but we see it as a binary. But what we're trying to do is look at and say, well, you can still do the job, or you can't. And that's not necessarily what we look at in terms of an occupational health setting. This is what we'd be looking at in a performance setting. So the industrial athlete concept recognises performance. It sits on that spectrum. It's people don't suddenly become incapable. They drift. Their readiness changes over time. Recovery changes, and the tolerance narrows. So connecting today's topics, again, we're just looking at everything that we've discussed here, which is muscle quality, metabolic health, osteoarthritis, and rate of force development. So these are system about resilience and on any given day. But what we look at in terms of elite sport is that we can support those increases. We can, training's adjusted, or recovery is prioritised, or monitoring becomes more important. So the big question here is what if we applied the same thinking to the people who work? So it's not to medicalise people, it's not to lower standards, but to recognise readiness is dynamic, and it's an early support protects people, but it also protects performance. So with that lens in mind, let's just finish off the rest of this puzzle here today. So I want you just to bring everything together. So this is one practical picture, and this is our ideas that we've talked about when they become visible without turning this into a medical or occupational health process. So this is something that we've been working on at Colmore Health, and it's typically based on our experience and evidence. And so what we think about is it's not about medicalising people, it's about looking at early visibility. So it's simple, consistent, and it's usable. What we tend to find is that when with companies that we've worked with previously is that we tend to find that lots of things are being done, but they seem to be all over the place, and they never sort of correlate together, and they're never observed together as one. So it's quite important that we take that factor on. So when we look here, if you look over onto the left-hand side, what you'll see, this is a MSK risk quadrant. And typically what you'll see is that most people sit up in the top right-hand corner of this. So this might be someone who's in pain. They might not be seeing anyone. They might not be monitored. They might not be given rehab. So people might be suffering in the background, but nothing's being done. What we want to try and do then is we want to try and move them back towards the green. And that's where we look at worst case scenarios when someone's in pain, and they're not being managed, they're not being monitored, and they're not diagnosed. So these are the people that would be classed as unknown unknowns, but we want to try and move them back down to where we can say, people have been diagnosed, they've got a condition, they've got a plan, and we're also monitoring them for their progress. So then as we sweep across then, come over to the next mobile show there. And what that looks at is that looks at more sort of the readiness of the individual. So the person individually on a daily basis, what they'll do is they actually go through, we look at the Karolinski score first of all, but we also look at sleep. So we ask sort of 5 basic questions to get an understanding of what their readiness is for the day. When we move over towards the third mobile screen there, what that shows us is there's a readiness overview, which is sort of weighted really on some of those scores. But what it also looks at is their blood markers, are they at risk, but also takes into account things like ultrasound scans that we've done and how we're actually managing that person from a user point of view. And then we come over to the final screen there, and that gives us the manager an overview of where we would see certain issues coming about within certain roles, within certain locations, what seems to be popping up the most, what are the trends within that area. So whilst this is evidence-based and whilst this is from experience, it's just really trying to get us to sort of think about how we manage musculoskeletal health. And it's more about how we're managing it. And I know from personal experience, and I know from a private clinic I'm working with on the rail, how we manage these populations. So it's just about combining this information together and just making obviously work and aging a lot easier. So that I'm wrapping up here now. So if there's anybody wants to ask any questions and answers, please feel free. If you haven't got anything there, then I'll be more than happy to answer them later. So let's have a look at some of the questions here. So I went from, let's have a look. So I went from a frontline role where I was walking 45k a day. I'm pretty sedentary as a 50-year-old. Now I've lost so much of the fitness and energy I used to have. What are some easy ways to build this up again? So without talking about in individual cases, it's quite hard in terms of that, because obviously I don't know what your obviously your background is. What we always say is, as you're getting older, muscle strength training becomes more important. If you look at some of the studies, what we're looking at, there's a real good book, Longevity, by Peter Attia, and what we look at is how if the correlation between strength and cardiovascular fitness. If we lose strength, our cardiovascular fitness drops off, which is a correlation between that. So I would, if it was me, I would be doing strength training versus. Well, not versus, but I would be doing a lot more strength training personally, especially if you become sedentary. So basic stuff, things like that you can do at work, for instance. You can do, I think in 2024, the BMJ suggested an isometric wall sit. So you could do an isometric wall sit. So that's like doing a squat against the wall. You can hold that for 2 minutes, take a rest for 2 minutes, back on it for 2 minutes, and do that 4 times, 3 times a week. And that's been shown not only to help with muscle strength, but is also shown to reduce blood pressure. So that's probably an easy win from that my point of view. What's the biggest mistake organisations make when supporting older workers' physical health? I think it's always a tricky one to answer this one. I think I think there's, in terms of recovery, I think there's a lot based on what people are expected to do. I think time away, not necessarily time away from work, that's the wrong proposition. I think the emphasis should be more about strength training as we get older. I think a lot of companies offer gym memberships, your employee assistance programs, and I just think that we're not selling it enough. I don't think it's. We know it's very high on the agenda. We know that musculoskeletal health is one of the top players for absence in the UK. Yet there's not enough push, I don't think, at work around strength training. That's my point of view. And that's also what the HSE supports, and it's what the NHS. And if you look at all the data behind it, that's where the specification is really. So strength training for me. Can you recommend any supplements for metabolic health? No, I can't. Not on that one, unfortunately. There is some evidence, I suppose, not necessarily. I suppose it's more about nutrition, not necessarily supplements. I know the American Journal for Metabolic Syndrome, especially for hypertension, showed that there was some benefit for flaxseed, which has been shown to be as potent, especially when it's milled, to be as potent as your first line of blood pressure medication, or Ramipril. So that's probably a good start. But what I would recommend as supplement, I would supplement getting out and exercising and eating better. Osteoarthritis in the knees. Best type of exercise to do, and do you recommend any supplements? I'm always asked about whether chondroitin helps with knee pain. The evidence out there is for and against, really. I think more than anything, exercise would be better. And again, exercise for knee depends on your severity at this stage. Unfortunately, I can't comment on individual cases, but typically leg extensions at the gym really help. And also, obviously, squats if you can do them, but obviously with different ranges. That's what we would typically give for rehabilitation. But they do vary, and it depends on the individual. Do you feel that aging workforce are not safety critical, should have regular medicals, such as those who provide assistance to work? Not necessarily. Again, this is probably more of an occupational health question rather than from a performance question. I'm not occupational health, so I can't comment on that as an individual case, unfortunately. On to the next one. Should we all be weightlifting reasonable parameters as we age? Absolutely. Yes, definitely. There should be no reason not to do some form of resistance training. And the studies, the National Institute for Clinical Excellence suggest that it's 3 times per week strength training. And like I said, if you haven't done strength training before and now you're relying on that, it's more important as you get older to start investing in that now. I'm nearly 60 and I've found my recovery takes a lot longer. Absolutely. I suffer from reoccurring injuries. I'm reasonably active, but a large frame makes prop forward. High blood pressure. It's time to concede defeat. I wouldn't say in terms of that to stop playing rugby. Probably change your position, but again, it's an individual case, so I wouldn't like to. I would like to comment on that too much, to be fair. Again, because I don't know the rest of your history, but no, I mean, there's some people would. I think again, there's lots of change in terms of that. I think if you have got a sport that you like and you enjoy and it's exercise, keep doing it. If it's causing you pain, discomfort, I would look at why it's causing you pain and discomfort, and then maybe get some exercise. You'll find that certain exercise will help you very quickly. So I wouldn't be. Don't rule it out. Don't rule it out. I would say speak to an osteopath, physio, to get some advice on that. I would open up the discussion. So if a frontline management team wanted to start with this, I would actually get some engagement, talk about it. There's some really basic tests that we can do. I mean, just ask the questions. And I think this is one of the things that Siemens do really, really well. I've worked with Siemens and they're fantastic. And the question that you ask is, are you physically and mentally fit for work? And I think that's absolutely fantastic because I think we've not necessarily and it might be quite controversial, but I think when we're talking about health generally, there is a lot of focus. There's a massive pendulum swing to mental health, and there's nothing wrong with that. I totally agree with that. When we look at supporting people, the main things that are happening in the background, and when we look at absence, yes, depression and anxiety is high up there. So is MSK, and I feel that sometimes that is overlooked. So I would sort of say open the dialogue for it. Open the dialogue. Ask people. When we ask people, "How are you?" Is any aches or pains? And if there is, how can we get around that? But what I would say is probably, and it depends on where you're coming from in terms of, if that's a manager talking there or it's not, is what should we do? Is if you haven't already, gym memberships, really good, or just get someone in to do some basic exercise. It's pretty straightforward. Okay, any other questions at all? No. Would I recommend cold water therapy? Cold water, again, this really depends on the person. So if you've got high blood pressure, I'd probably be a little bit cautious, just because some of the pressure that can put onto the heart. But generally, cold water therapy, if you feel like it's good for you, do it. Make sure you're doing it safely. Cryotherapy does work. But yeah, okay. Guys, thanks very much. It's been an absolute pleasure today. Like I said, my details are there. Feel free to drop me an email. More than happy to pick up with you from on the other side.